Let's get right into it. We're breaking down high-yield gastrointestinal and systemic pathologies for USMLE Step 2 and 3. We're structuring this around the diagnostic funnel, which means optimizing your decision logic for the exam. No fluff today, just the exact facts you need to quickly narrow a differential and nail the right management.
Here's the plan. We've got 5 main areas: hepatic and biliary syndromes, small intestinal pathologies, the acute abdomen, severe colonic infections, and finally, systemic crises and toxidromes.
Starting off with Section 1, Hepatic and Biliary Syndromes.
If you've got a patient with advanced cirrhosis, portal hypertension, and edema, you absolutely have to watch out for hepatorenal syndrome. This happens when renal perfusion drops. It's usually triggered by things like excessive diuretic use, a GI bleed, or NSAIDs, because NSAIDs constrict those afferent arterioles. The diagnostic criteria are super specific. You're looking for a fractional excretion of sodium, or FeNA, of less than 1% and absolutely no signs of tubular injury. But here's the kicker. Unlike your standard hypovolemic acute kidney injury, hepatorenal syndrome does not improve with IV fluids. To treat it, you have to fix the precipitating factor and use splanchnic vasoconstrictors. We're talking meds like midodrine or octreotide to clamp down on those abdominal blood vessels and shunt blood right back to the kidneys.
Now let's flip that and look at Budd-Chiari syndrome. This is a hepatic venous outflow obstruction. On the boards, they love to tie this to a myeloproliferative disorder like polycythemia vera, so always keep an eye out for JAK2 mutation testing. The presentation really comes down to the timeline. Acute cases hit hard with jaundice and hepatic encephalopathy, but your subacute or chronic cases are sneakier: vague, progressive abdominal pain, hepatomegaly, and ascites. To confirm the diagnosis, you want an abdominal Doppler ultrasound showing decreased flow in the hepatic vein.
Take a look at this classic imaging for primary sclerosing cholangitis, or PSC. You see that multifocal narrowing? It's often called a beaded appearance, and it happens alongside intrahepatic and extrahepatic duct dilation. If you see this on a cholangiogram, you're done. You don't even need a liver biopsy to diagnose it. And as a quick reflex for the test, if a 42-year-old guy comes in with abdominal pain, bloody stools, fatigue, and an elevated alk phos, your brain should instantly jump to ulcerative colitis paired with primary sclerosing cholangitis.
Moving on to Section 2, Small Intestinal Pathologies. Time to test your decision logic. Let's say a patient meets the Rome-4 criteria for irritable bowel syndrome, meaning they've got recurrent abdominal pain linked to defecation and a change in stool frequency or form. But they don't have any alarm features: no unintended weight loss, no nocturnal diarrhea, no GI bleeding. How do we properly evaluate them?
Well, you have to split them up based on their dominant symptom. For the constipation-predominant folks, a simple CBC is all you need. If it's normal, treat them for IBS-C. But for diarrhea-predominant patients, the workup is a lot more intense. You still get the CBC, but you also need to grab a stool culture, run celiac disease serology, and check an inflammatory marker like CRP or fecal calprotectin. You have to definitively rule out inflammatory bowel disease before calling it IBS-D.
Let's add small intestinal bacterial overgrowth, or SIBO, to our malabsorption differential. Rule number 1, if the patient has totally regular bowel movements, SIBO is off the table. You're looking for chronic watery diarrhea and bloating in someone with risk factors. Think anatomic abnormalities, motility issues like diabetes or systemic sclerosis, or even gastric hypochlorhydria from taking PPIs forever. The lab findings are actually really cool here. You'll typically see a drop in vitamin B12 because the overgrown bacteria are eating it up, but you'll see an elevated folate level because those same bacteria are synthesizing it. You lock in the diagnosis with a carbohydrate breath test using lactulose or glucose.
On to Section 3, the acute abdomen.
Physical exam signs are your best friend for rapidly localizing the appendix, and you need to know exactly what each one tells you. Rebound tenderness? That tells you there's peritoneal irritation and it's probably about to rupture. But the localizing signs are what you really want. The psoas sign, where they get right lower quadrant pain when you extend their right thigh, strongly points to a retrocecal appendix or an abscess. Right on the psoas, the obturator sign and right-sided rectal tenderness, those firmly plant the appendix in the pelvis. And of course, Rovsin sign, where pushing on the left lower quadrant causes pain on the right, is your classic red flag for acute appendicitis.
Here's a huge pitfall. You always have to differentiate true appendicitis from infectious ileocecus, which is basically a fake appendicitis. Campylobacter gastroenteritis is a notorious mimic.
Both give you right lower quadrant pain, but true appendicitis usually just causes mild diarrhea. Campylobacter, on the other hand, gives you profuse, mucoid, and sometimes bloody, inflammatory diarrhea. The history will usually mention undercooked poultry exposure. Most of the time, it's self-limited and you just use supportive care. But don't forget it carries the serious risk of triggering Guillain-Barré syndrome down the line.
Here's another high-yield scenario. You've got a patient with colicky abdominal pain, a totally distended and tympanic abdomen, and an X-ray showing dilated loops of bowel with air fluid levels. It's obviously a small bowel obstruction, but what is your very first move when this patient suddenly spikes a fever, their blood pressure tanks, and their heart rate skyrockets?
Those vitals are massive red flags. Fever, hypotension, and tachycardia scream systemic toxicity. They're telling you the bowel is ischemic, necrotic, or already perforated. The obstruction is strangulated, which means you immediately abandon supportive care. Stop the NG tube decompression, stop the bowel rest, and get them straight to the OR for urgent surgical exploration.
Section 4. Severe colonic infections.
Let's talk diverticular disease. What's the most common cause of gross lower GI bleeding in adults? Diverticulosis. It's super common, especially with low-fiber diets and a lot of red meat. But things get complicated when that turns into acute diverticulitis, especially if there's a large abscess involved.
So, you get a CT scan showing focal bowel wall thickening and boom, you've confirmed acute diverticulitis. Uncomplicated cases just get oral or IV antibiotics, no big deal. But if you see an abscess that's larger than 4 centimeters, the rules change. You have to go straight to CT-guided percutaneous drainage while hitting them with IV antibiotics. You only take them to surgery if the drainage fails. If the abscess is under 4 centimeters, you can usually just manage it conservatively with IV antibiotics. You also need to be hypervigilant for toxic megacolon, which is a true medical emergency. It's severe colonic smooth muscle inflammation and paralysis, usually complicating IBD or infectious colitis. Here's a pro tip. Do not give antimotility agents like loprimide or opioids to someone with infectious colitis. It drastically increases their risk of developing this. You confirm it when you see the colon dilated over 6 centimeters on an abdominal X-ray, plus signs of systemic toxicity like fever and hypotension. You manage it with bowel decompression and antibiotics, and maybe steroids if it's IBD, and absolutely no enemas or colonoscopies. The risk of blowing a hole in the colon is just way too high.
For Clostridium difficile infections, especially after recent antibiotics or a hospital stay, everything depends on how severe it is. The classic presentation is 3 or more watery, loose stools in 24 hours. We categorize severity by looking at their white count and creatinine. For non-severe cases, so white count under 15,000 and creatinine under 1.5, you use oral fidexamycin or oral vancomycin. But if they're fulminant, meaning they're in shock, hypotensive, or they have an ileus where the intestines stop contracting, you hit them with dual therapy. That means oral vancomycin combined with IV metronidazole. If they have an ileus, you might also need to throw in a vancomycin enema.
Let's bring it home with Section 5, Systemic Crises and Toxidromes.
You've got to be able to tell acute from chronic disseminated intravascular coagulation, or DIC. Acute DIC is usually set off by sepsis, severe trauma, or obstetrician emergencies. It chews through coagulation factors fast, so you see prolonged coags, low platelets, and a massive risk of severe bleeding. Chronic DIC is completely different. It's driven by underlying malignancies like pancreatic cancer. The body actually compensates over time, so their coagulation studies, platelets, and fibrinogen might look completely normal. The real danger in chronic DIC isn't bleeding at all. It's a super high risk for severe thromboembolism. Oh, and both types will show an elevated D-dimer, so don't let that trick you.
In pediatrics, Henoch-Schönlein purpura, or HSP, is a systemic vasculitis you have to spot a mile away. Look for the classic diagnostic tetrad, palpable purpura, mostly on the legs and buttocks, arthralgias, renal issues like hematuria, and intense abdominal pain. That abdominal pain is a high-yield exam clue because it's frequently caused by an ilio-ileal intussusception. Keep in mind, typical pediatric intussusceptions are often treated with an enema, but ilio-ileal intussusceptions from HSP usually require actual surgical management.
Wrapping up with a major toxidrome. If a patient is drooling everywhere, can't swallow, and has a white tongue, think caustic ingestion. But for anticholinergic toxicity, just rattle off this mnemonic. Hot as a hair because they can't sweat. Dry as a bone from totally shut down glandular secretions. Red as a beet from superficial vasodilation.
Blind as a bat because the ciliary muscle is paralyzed and the pupils are blown. Mad as a hatter from the central nervous system effects. Full as a flask because they've got urinary retention and constipation. And fast as a fiddle because decreased vagal tone at the SA node sends their heart rate through the roof.
Clinical mastery on the wards and on the boards relies entirely on rapidly linking these isolated physiological variables into definitive management pathways. When you evaluate a patient, you aren't just looking at a single symptom. You're mapping the entire diagnostic funnel from the initial exposure or precipitating risk factor straight down to the definitive treatment. Keep refining that clinical logic. That's the overview for today.